Drug use has been a part of society for an awful long time, and our attempts to eradicate drug use haven't worked. So, we need to explore different options, and, it's up to community leaders to actually lead that discussion.
Hello and welcome to Wellbeing. I'm Jack Hodgins. Today is the second and final episode delving into what drug addiction is. We are joined by Professor Paul Dietze, one of Australia's leading alcohol and other drug epidemiologists, with a significant national and emerging international profile. He has contributed many innovations to his field, receiving $20 million of research funds over the course of his researching career. He has received numerous awards and prizes in recognition of his work. Hello, Paul, and welcome back to the program.
Thanks, Jack.
Are addictions a disease?
So that's a thorny question. So there's lots of descriptions of drug use and so-called addiction as a disease, and the disease concept has its place. It's useful, and it's in terms of being able to shift the focus away from the person who's consuming the drug. So, there used to be, and there still is to a certain extent, a lot of moralising goes on around drug use. To call addiction a disease as such means that it can lead people away from that moralising, and you have lots of claims about addiction being a chronic relapsing disease condition, and it does sort of show some of those sorts of features and so on. The problem with calling it a disease is that we don't really have a fundamental understanding of exactly how all of these things are happening, and we don't have, and it leads to in some respects, an excessive medicalisation of what is essentially a form of human behaviour that's been around for an awful long time. So the concept as used is useful, but not but not perfect.
Are most of the drugs that are on the street, how prevalent is, say, the bad ones to, as in you're getting it from someone and they've, cut it with something that, could potentially kill you? How safe is that for people that are getting their drugs off the street?
There has been some work that shows that most of the problems that people are going to experience with the drugs that they purchase relate primarily to the drug itself. But sometimes you might find there being adulterants that might have an impact. Often they're other illicit drugs. So recently in New South Wales, there was some cocaine, substances sold as cocaine that contained illicit fentanyl. And that led to some harms that's being experienced by people, and led to a New South Wales Health issuing an alert about that. And so those kinds of things can have an impact. There's ultimately, it's very difficult to know exactly what people are consuming, and we rely a lot on the sort of testing of seizures and so on. Increasingly, we're doing some drug checking sort of initiatives. So there's some harm reduction organisations that have been working to use, for example, fentanyl test strips, which are simply administered testing strips that can be used to detect whether or not fentanyl's in a particular sample. And that can lead to changes in behaviour if people don't want to take fentanyl, for example, if they detect it, and so on. And similarly, there's drug checking that's going on for festival patrons around the world in different locations, and we'll see that it's actually been formally legalised in New Zealand just recently. We've had some trials of that kind of initiative at a couple of festivals in Canberra, but at the moment, drug checking outside of those festivals in Australia isn't permissible. But it allows people at least to gauge whether or not their tablets and so on actually have the substance that they expect to have, and whether or not there might be any significant adulterants in there that might make them change their mind about taking it.
Can they change the brain permanently or for a time in any way?
Absolutely. So there is clear evidence that there are changes to brain function that go with certain types of drug use, and some of that can be kind of permanent in a sense, but we do know that there are effective drug treatments that can reverse the course of a lot of those kinds of impacts.
Would you mind telling us a little bit about how you got involved with the topic in your career? And
Sure. So I've actually got a background in psychology. That's where I did what I did my PhD in, and I did it in a completely unrelated area to forensic psychology around child eyewitness memory. And then I basically came into the field doing an initial a short-term project for a alcohol and other drug centre down here in Melbourne, and then decided that was there was lots of opportunity and lots of scope to actually do what I hoped would be important and useful work, and haven't looked back since.
Do you have any research you're looking into at the moment?
I have a whole range of different research projects going on, and there's some fantastic work going on across the country. Australia is really lucky to have really an amazing network of state-funded drug and alcohol research centres. So we have the National Drug and Alcohol Research Centre in Sydney. We have National Drug Research Institute in Perth. We've got a youth substance use research centre in Queensland. We've got Turning Point Alcohol and Drug Centre in Melbourne. We've got the Burnet Institute, where I'm based, as well as the National Drug Research Institute, for example. So we have an incredible amount of research that's going on. We have really important work that's going on in relation to specific drug treatments and improvements in drug treatment. We've got some fantastic policy work going on in relation to different types of drug policy based at the University of New South Wales. We've got similarly important work going on in relation to alcohol policy from people based in Newcastle and Deakin University and so on. So we're really lucky in Australia. In the work that I've been involved in, we have been looking a lot at the impact of the Melbourne Supervised Injecting Room, for example. So we run studies that enable us to look at comparing people who use the facility and their outcomes against people who don't use the facility, looking to see whether or not the facility has any kind of clear benefit. And what we've shown, for example, is that people who use the facility a lot for their injecting episodes, they're much less likely to experience an opioid overdose attended by ambulance, for example. So, able to demonstrate the benefits that go with use of the facility. And we're also looking specifically at methamphetamine use in Melbourne versus the rest of rural Victoria, and looking to see, what sort of things are going on there in relation to people accessing treatment, whether or not they're engaging in any kind of drug driving behaviours, and whether or not they're more likely to be arrested, all sorts of things like that. So we have a huge range of projects going on at the moment.
You're listening to Wellbeing, where we're discussing what drug addiction is. My guest today is Professor Paul Dietze, a leading researcher in the drug and alcohol field. Do you have a project that you've done in your career which you say that's like one of your proudest kind of projects you've worked on?
Yeah, I'm really proud of all of the work that I've been involved in. I'm really most sort of proud as such of my of the work that my students engage in, and I think we've achieved some amazing outcomes. One of my favourite studies is one that looked at people who experienced a heroin overdose and what sort of risk factors went with that, and we employed a sophisticated research design to that question, and showed clearly for the first time how people shifting their location of use. So if they were normally injecting in a private location and they moved to a public location, they were more at risk of overdose. If they changed their dose, we demonstrated that people who used a particular amount, if they shifted that to increase the amount that they were using, then they were more at risk of overdose. And that dispelled a bit of a myth that went on that it wasn't, that dose was unimportant. It was prevalent at the time. So there's a whole range of things that I'm really proud of over my career, but that's one example. And the other thing is that we've increasingly been working to ensure that people who are at risk of overdose, opioid overdose that is, have access to a drug called naloxone, which is a very efficient opioid overdose reversal drug. It has very few other properties. It's not open to abuse or anything like that. But what it does is it reverses the effects of opioids incredibly efficiently. So if someone has an overdose and you administer naloxone, and it can be done either through muscular injection or through a nasal spray nowadays, basically people come around and basically makes opioid overdose something that's completely preventable. I've been involved in a range of projects around the country where people have worked really hard to get naloxone out to people at risk, and I think we've been doing that more and more effectively, and it's led to a whole range of developments in New South Wales. The work that's going on led by the Department of Health, and then a whole range of non-government organisations has really sort of started to spread naloxone availability really widely. And I've been involved internationally as well, running a project in 4 countries, 3 in Central Asia and then Ukraine, looking at trying to expand naloxone there as well. So there are a whole range of responses that people have got in the armoury now, and it's really it's been great to be a part of trying to pull that kind of work together.
Can drugs affect the different genders differently?
Absolutely. So there are, even just down to body mass and so on. So if you have the same dose of alcohol, for example, someone who's bigger, and typically men are bigger than women, will potentially have less impact. And there's some drugs that are fat soluble, for example, that women typically have a slightly higher fat content. So as a consequence, we'll have differences in the way that the drugs are expressed over time, and so on. So there are some gendered impacts, but it also relates more broadly to our construction of gender in society as well. So, men do certain things, and the ways in which they go on to experience the effects of drug are gendered as well. So that comes from the society that we live in, rather than any specific drug effect itself.
Are there any demographics that are more likely to develop a bad habit with drugs?
There's a whole range of answers to that question, but fundamentally, we do see people who are of more limited means and so on. They often go on to experience drug-related problems and so forth. But a lot of that is coming from just elements to do with their background. So it might be the experience of trauma, for example, and so on. So I don't think you can actually, in the main, say that it's any specific demographic as such. But what it is that there's a whole confluence of social circumstances that sit behind drug use, and those sorts of things are really important. So, if people who are unemployed, for example, we often see that there's a lot of unemployment in our samples. That's not unemployment driving drug use necessarily. It's it's a confluence of circumstances that leads to unemployment. So the causal path for all of these sorts of demographic impacts we need to properly unpick.
Can genetics in some ways predetermine someone to have be more likely to develop an addiction in any way?
So there's undoubtedly some kind of genetic impact in relation to drug use and drug-related harms, but that's not definitive. So it is also about the environment, as I was mentioning before.
In its current understanding, does society understand addiction?
I think it does a pretty poor job in the main, and as we've been talking about, there's lots of stigma that goes with people who use substances, and lots of examples of that right through the community, and that really does impact on the experience that people will have and their willingness to engage in services. They could end up incarcerated. Once incarcerated, that leads to much more limited opportunities upon release for employment, for housing, all of those sorts of things, and leads to people experiencing problems unnecessarily.
When someone has an addiction to drugs, how can that affect relationships with family members, friends, and work colleagues?
So basically, there's a whole range of impacts, and there's a range of harms that might be experienced by people other than the person who's using substances. So, compulsive use can lead to all sorts of problems that are typically constructive, but there's other forms of use so people don't necessarily need to be addicted to a substance, to use your term, for their family and wider community to experience harm. So we see people who would not normally engage in violent behaviour might engage in violent behaviour. Part of that related to the drug use, part of that related to the setting in which it's taking place, and so on. And then extreme harms can be experienced.
When it is more the extreme end, how can family members help the situation? What are some strategies they could do?
Well, first off, there are a range of supports for family members. So there's telephone helplines. So I think in New South Wales it's called ADIS, the Alcohol and Other Drug Information Service, I think it's called. Then there's also family-specific telephone helplines like family drug support, and those helplines offer trained counselling about how to begin approaching issues, and it's useful to take advantage of those systems and services. So there's a range of supports available. Contacting drug treatment services and so on can help. So it's about exploring the range of options that are there, and you don't necessarily just begin by confronting someone or anything like that. There's a range of services and a range of options to pursue.
When should someone undertake recovery?
When they're ready to, essentially. So, what as a society we need to do is to ensure that we essentially keep people alive until they're ready to change behaviours that might be problematic. That leads to a whole range of harm reduction types of initiatives. And then working to ensure that they have the right supports to make the decisions that are going to help them and help their community.
You're listening to Wellbeing, where we're discussing what drug addiction is. My guest today is Professor Paul Dietze, a leading researcher in the drug and alcohol field. What are some of the challenges within going to that kind of place? Like, what are the challenges in coming to that decision, do you think?
Well, there's a whole range of challenges that go with it. I mean, part of it's about availability of supports and the types of experiences that people might have had. As we've been talking about, there's stigma and discrimination at some health services, for example, which leads people to essentially have a lack of trust, and they wouldn't necessarily want to disclose their drug use because of the stigma and discrimination that goes with it. And then we generally don't have enough treatment options that are effective available when people need them. So there's all sorts of issues to do with waiting lists. Some of our treatments that are available aren't as effective as you would hope. And we need to properly resource our treatment service system to make sure that there's not people are often quite vulnerable when they want to access drug treatment and so on, and people are often willing to pay a lot of money for what can often be pretty dodgy sorts of services. So it's important to take advantage of the strong non-government organisation network that's around, and government organisations, of course, in some parts of the country. And the place to start for referrals and so on is through telephone helplines and other support services that are available. And, it's using those to make those steps.
How well, in the current form, are the programs and the places that help with recovery doing in approaching recovery?
Well, a lot of them are very sophisticated in their approach, and we have really effective tools for some drug use disorders. So we've got things like methadone and buprenorphine available for people who have opioid problems, like with heroin, for example. And then, increasingly we're seeing more and more sophisticated approaches to what people call rehab. So this is often, where you go in for residential services and so on. And it's important to make sure that we do have a strong workforce. This is something that's really important. We need to make sure that the workforce is properly trained and supported and remunerated. I mean, it's not like people in the workforce are being paid an awful lot of money or anything like that, and that's something that really does need to be addressed.
And when they do get to recovery, what are some of the challenges that they can go through, such as like withdrawals?
So certainly, if someone starts to, if someone is engaging in compulsive use and they've developed tolerance to the effects of the substance, then yes, they will experience a withdrawal syndrome when they stop using. And managing withdrawal is a really important function that drug treatment services can provide, and they can do that sometimes inpatient, sometimes outpatient. But it's important to provide post-withdrawal support. Withdrawal on its own isn't sufficient. So, but yeah, certainly people can experience withdrawal, but it's manageable, and there are support services available to ensure that people can get through.
Would you say that one of the most important things in creating a society that has a good relationship with drugs is education?
Yeah, absolutely. And but there are some evidence-based education programs and packages that are around. So there's some great work from the National Drug Research Institute, and also increasingly from the Matilda Centre in Sydney on effective approaches to drug treatment. To drug education, but there are ineffective approaches as well, and we often rely on those. We think about shock tactics and so on as being something that will be effective, and the evidence is that most of the kind of shock tactic programs don't actually work. So, but there are a range of education initiatives that can work, and targeting people through strong relationships with their peer networks and those sorts of things is a really important way to go.
From here, what needs to, from all the things we've talked about, from here, what's the next step in making sure that stigma, and all the goals that we've talked about in improving how we view drugs, what do we need to do?
Well, look, there's a whole range of things that we need to do. So we need to properly implement all of the initiatives that are available. So there's there's things that we're not implementing to the extent that we should and could. So that's things like our effective drug treatments need to be made more available and need to be available when people need them. And then, we then need to engage in, work out ways of reducing stigma and discrimination. There's lots of attitudes that need to be changed, and part of that's just about making people understand that drug use has been a part of society for an awful long time, and our attempts to eradicate drug use haven't worked. So we need to explore different options, and it's up to community leaders to actually lead that discussion.
Well, thank you for your time today, Paul. That was a pleasure talking with you.
No worries. Thanks, Jeff.
This is the second and final episode delving into what drug addiction is. My guest today is Professor Paul Dietze, one of Australia's leading epidemiologists in the alcohol and drug field. Thank you for listening. I'm Jack Hodgins, and all of us at Wellbeing wish you well.